Welcome to part 2 of Mastering the CMS Team Initiative. In this section, we're going to shift our focus from the foundation we've built to the direct impact on surgical care. But before we dive in, let's recap what we covered in part 1. We introduced the Transforming Episode Accountability Model or team and discussed why it was important. We also looked at its 4 pillars: extended accountability, building on prior programs, combining cost and quality, and tying payment directly to performance. We also explored the financial, clinical, compliance, and public reporting implications. And we reviewed the timeline with 2025 as the preparation year and January 2026 as the official start and public reporting soon thereafter. This sets the foundation for today's presentation on surgical care. For those of you joining me here for the first time, my name is Aisha Kulo and I'm the Chief Nurse Executive with the Institute of Post-Acute Care. I bring with me over 20 years of nursing leadership experience. I've led hospitals through CMS initiatives, strengthened compliance programs, and worked directly with frontline teams to improve patient outcomes. In this section, I'll be guiding you through how this model directly affects inpatient surgical care. So, in this section, we'll examine the impact on surgical care. We will start with a high-level look at how surgical delivery is going to change. Next, we'll review the specific procedures included under this model, and we'll explore how surgical episodes are defined. Finally, we'll discuss the quality matrix hospitals will be evaluated on, and by the end of this section, you'll have a clear picture of what surgical care looks like under this model. So here's our agenda for part 2. First, the overall impact on surgical care. Second, the surgical procedures included. Third, the structure of the surgical episode itself. Fourth, the quality matrix tied to reimbursement. And finally, the risk and implications of non-compliance. Each topic builds on the other to create a full view of what hospitals must prepare for. So let's take a look at the impact on surgical care. This model reshapes how surgical care is delivered and judged. As I said in my previous slides, hospitals will no longer be evaluated solely on the technical success of a procedure. Instead, you will be judged on the entire care journey, from the moment of admission through surgery and inpatient care, into discharge, and for 30 days after the patient leaves the hospital. This means hospitals must deliver consistent evidence-based care to ensure smooth handoffs and prepare patients to succeed at home. Gaps at any point can negatively affect performance as well as reimbursement. Surgical procedures affected. The model applies to a wide range of inpatient surgical procedures. This includes orthopedic surgeries such as hip and knee replacement and spinal fusions, general surgeries such as colectomies, gallbladder removal, and hernia repairs, cardiac procedures like bypass grafts, valve replacements, and selected neurological, gynecological, and urologic procedures. Because the scope is so broad, nearly every surgical specialty in the hospital will be touched by these changes. So let's define a surgical episode. A surgical episode is defined as a continuum of care. It begins with pre-admission assessments and preparation and continues through the inpatient stay where evidence-based protocols are applied. This includes discharge planning and documentation and extends into the 30-day post-discharge period. Hospitals must demonstrate excellence at each stage to meet the performance expectations. Consider a patient undergoing spinal fusion. Pre-admission will involve identifying risk factors such as diabetes, smoking, and addressing them before surgery. During the inpatient stay, standardized infection prevention and mobility protocols are followed. At discharge, medication reconciliation is completed and clear instructions are provided to the patient. And in the 30 days following discharge, follow-up calls ensure the patient is recovering safely at home. Each of these steps, if documented and carried out consistently, improves outcomes and strengthens your performance scores. Let's take a look at how performance will actually be judged. So CMS uses 4 categories of quality metrics. The first is your clinical outcomes. This includes your readmission rates, your infections, as well as your mortality rates. CMS will validate these outcomes through claims data as well as documentation in your medical records. Second is process utilization. So this measures whether hospitals are following evidence-based standards and documenting care transitions appropriately. Some organizations are already implementing programs such as a first-day home follow-up to confirm patients have their medications and then continuing with weekly calls throughout that 30-day period. These practices strengthen both compliance and performance. Third is the patient experience, and this is measured through your standardized surveys and tools like the patient reported outcome measures or PROMs, which capture patient satisfaction and their perception of recovery. Finally is your resource utilization, which looks at efficiency measures such as your length of stay, post-acute service use, and overall resource consumptions. So together, these 4 categories, outcomes, processes, patient experience, and resource use, create a balanced evaluation of surgical performance. Beyond the financial penalties, the risk of not meeting these standards are significant. Hospitals can face financial penalties of up to 5% of Medicare payments. Surveyors will also scrutinize documentation as well as your transitions of care more closely. Lower public scores may damage reputation and reduce patient trust, and in competitive markets, weaker performance may even affect your referrals and market share. So what does this mean? Compliance is no longer optional. It's essential for both financial as well as the trust from the community. So we've gone from fee-for-service to value-based care. So now that we've talked about financial penalties, let's take a step back and look at the bigger shift that's happening in healthcare payment. So under our traditional fee-for-service model, hospitals were paid for each individual service. So this means an imaging test, a lab draw, or the surgery itself was paid separately. The system created incentives based on volume and not outcomes. Care was often fragmented, which limited accountability once the patient left the hospital. The new value-based model is very, very different. Payment is now episode-based. This means payment will cover the entire patient journey from admission through 30 days post-discharge. Incentives are tied directly to quality and outcomes. This model requires seamless coordination across the care team, and accountability is extended well beyond the hospital stay. Let's take a look at this example. Under fee-for-service, if a patient underwent a total knee replacement, the hospital and surgeon were reimbursed for the procedure itself, physical therapy, imaging, and any follow-up visits. All of this was billed separately. If the patient was readmitted with an infection, that readmission also generated additional revenue. So what's changing? Under the new value-based model, the hospital is paid for the entire knee replacement episode as one bundle. So if the patient is admitted due to infection, that cost is going to be absorbed by the hospital and not reimbursed by CMS. So what does this mean? Preventing complication isn't just good enough anymore. It's essential to financial survival. To summarize part 2, we reviewed the overall impact on surgical care. The procedures included the structure of surgical episodes and the metrics hospitals will be judged on. We also highlighted the risk of non-compliance. In part 3, we will shift from what is expected to how hospitals can prepare their clinical teams to meet these new requirements. Stay tuned and join me.